A very good evening, my dear FMG friends, and I hope all of you are doing well. So, we are today here for a recall session for ophthalmology questions which were asked in your 26 July FMG exam. I hope you have rested well and you are rejuvenating yourself well and take care of yourself. So let's begin with our session, and before I start the session, as you are aware that these questions, they are based upon the recall by the students, by you people. So we have tried to compile the questions based upon the recall. Of course, they are not, exactly similar to the questions which were asked in the exam, or even the choices or the options which were given to us. But based upon the recall, we are able to compile the questions and we are going to discuss these with you. Okay, so let me start with the first question in the recall session, which was asked in the recent exam. Now, this question was, I would say, a question which has been discussed very well in the classes, in the mock test, in the sessions. Okay, and I hope you were able to attempt this question correctly in the exam. It was a clinical case scenario, most likely something like a female patient has sudden onset pain with redness in the eye and decreased vision. So if you remember, I have always told you the scenarios or the differential diagnosis of painful red eye and decreased vision. Okay, so we'll come to that. Now, on examination, there is hazy cornea with mid-dilated pupil and shallow anterior chamber. If these two things, they were there in the question statement in the exam, so I hope that the answer was very clear to you. Okay, hazy cornea, mid-dilated pupil, shallow anterior chamber. So whenever we hear the word or we read the word shallow anterior chamber, so that should take us to angle closure glaucoma, or it means that this person has the anterior chamber which is shallow and the angles which are narrow or closed. Okay, so decreased vision with painful red eye, mid dilated pupil which is not reacting to light, it can be oval in shaped, hazy cornea. The corneal haze is because of the corneal edema, which is there because of the high intraocular pressure. So obviously, as all of you are telling me, and I hope you marked it right in the exam as well. So the answer is acute angle closure glaucoma. Acute angle closure glaucoma. Coming to the other choices which were possibly there, why it is not uveitis or acute anterior uveitis? Because anterior uveitis is another cause of painful red eye with decreased vision. But the chamber is not shallow in anterior uveitis unless it is a secondary angle closure, and the pupil is always either irregular due to posterior synecdoche. So you will find an irregular pupil due to posterior synecdoche or a small pupil. Irregular pupil or small pupil in cases of acute anterior uveitis. Okay. Then acute conjunctivitis, if that is an option, so you can rule it out that there will not be decreased vision. Again, no hazy cornea, no mid-dilated pupil. Open angle glaucoma will not have shallow anterior chamber. It will have deep anterior chamber, and it rarely presents as an acute attack of very high intraocular pressure. Okay, so this clinical case scenario was typical, very bookmark clinical scenario for acute angle closure glaucoma. Okay, and if you remember the clinical picture, so that's why we learn a lot with the help of the images in the classes and in the revision lectures as well, because if you have the clinical image in mind, you can always attempt the question. So this is how this patient will look like. So when there is acute congestive glaucoma or acute attack of angle closure glaucoma, there is pupil block. Because of the pupil block, the lens iris diaphragm is pushed forward, intraocular pressure goes up to the range of even 60 to 70 millimeter of mercury, very, very high intraocular pressure, with stony hard eye, which leads to corneal haze. Because of such a high pressure, the iris sphincter muscle becomes ischemic, so pupil becomes non-reactive to the light, mid-dilated in position, chamber will be shallow, and just a quick word about this is an ocular emergency. So here the first step will be to bring down the intraocular pressure very fast, and for that we will use IV mannitol or Diamox to control the pressure, and then you start the patient onto intensive therapy with pilocarpine, because once the pressure is down, then the pilocarpine will constrict the pupil and relieve the pupil block. Okay, so just a brief about that, and I'm very sure that all of you were able to mark this question right in your exam. Going to the next question, beta. Again, this question, if you remember, this was discussed even in the 25 important questions session which we had in ophthalmology. A patient presenting after a road traffic accident, radiological image showing this finding. This radiological picture has been very familiar to all of you. So when we see in radiological imaging that there is, now this is the roof of the orbit, this is the medial wall of the orbit, this is the lateral wall of the orbit, and this is the floor of the orbit. So when there is blowout fracture of the floor of the orbit, the orbital contents, they herniate into maxillary antrum, producing a classical teardrop sign. So if you were able to identify the teardrop sign here, so answer was very, very clear. You even did not have to look at any other option in this case, because orbital floor blowout fracture is a very straightforward diagnosis when this radiological picture is seen. And again, I am very sure that we have discussed it and all of you would have marked it correctly. Okay, right? Moving to another image-based question which was asked in the exam, where they showed you this optical diagram and they asked you to identify the refractive error. Okay, and friends, I would like you to let me know if you want to add to any question, if you have more information about any question, or if we miss any question in this session, so you can tell me in the comments and we can add on to that. Okay, because this is a recall session. So again, this image has been discussed in our classes. I think even in some of the mock tests or the test discussion which you would have done. This is an optical diagram of regular astigmatism. Okay, so when there is an astigmatic surface or toric surface, so what do we mean by toric surface? When the vertical meridian and horizontal meridian, they do not have similar curvature. Okay, cornea is not perfectly round. When the cornea is not perfectly round, the vertical meridian will have different corneal curvature, horizontal meridian will have different corneal curvature, and that is what we call a toric optical surface. Okay, so this diagram, this optical diagram represents that when light rays, they strike a toric optical surface, how there are not a single focal point, there are multiple focal points. There is a different point where the rays from the horizontal meridian, they will focus, and there is a different point where the rays from the vertical meridian will focus, and that is called astigmatism. Very right, Dr. Thakur. So this is representing regular astigmatism, and this particular image of the optic which is shown here is called Sturm's conoid. It is called Sturm's conoid. Okay, again, I think this should have been a correct question for you. This is not representing presbyopia. If that was the option, presbyopia we know is when with age, usually after the age of 40 to 45 years, the capacity of accommodation decreases and you have to use plus glasses for reading or for near work. It is not representing myopia. In myopia, the light of the rays, they focus in front of the retina, but all the rays, they focus at a single meridian. In hypermetropia, they focus behind the retina, but again at a single focus. So here, but you see there are multiple foci. Okay, so that should have been the key to you, that what is this, or what is the right answer for this. Okay, right? Okay, coming to your next question. Now this question again, because if the statement was like what I have mentioned here, what we have gathered from you, if the statement was like this, again, then it was a very straightforward question. I agree that sometimes the question statements, they're a little tricky in the exam, but if you are able to identify the key points and they were given, so again, this was a good question. The question was something like, a patient presents with linear branching corneal ulcer. So here they used I would say a little newer terminology, but we understand branching, tree-like, isn't it? Linear branching corneal ulceration. I hope the image was given. So if this image was given, the answer was more straightforward. If the image was not given, even then, if these words, they were there, reduced corneal sensations. Now, if you think of the reduced corneal sensation, so that can occur in what type of the infective ulcer? Only one type of the infective ulcer causes reduced corneal sensations, and that is your herpes, right? Herpes virus. The reduced sensations, they can be in fifth nerve palsy and other causes, but the shape of the ulcer was the second point. So these 2 points, shape of the ulcer, linear branching. Linear branching means what we have been calling dendritic ulcer. See, so this is a kind of a branch, a linear ulcer, and then branches going from here like dendritic. Okay, right? So acute congestive glaucoma and acute, Dr. Madan, acute angle closure glaucoma is one and the same thing. So if both were given, which I think will be unlikely, I don't think they gave acute angle closure also and congestive also. But if they gave, then acute congestive, because that is, we use the term when the pressure is very, very high and the kind of thing there. Okay, so acute congestive glaucoma was the right. So I think the exam level is already for the last few times has been similar to NEET PG. If you see the last exam, if you see the exam prior to that, ठीक है, अब वो लेवल जो है नीट पीजी का और एफएमजी का बहुत क्लोज आ गया है, and that is what I tell you in the classes also. So that is why it is important to avoid any shortcuts, बच्चे. That is why it is important that when you are attending a session, try to build the concepts which will help you in the exam. Okay? So as I'm discussing the ophthalmology recall here, so you can see these are the things which we have been discussing in our classes, in our revision classes, test discussion sessions, in the important question sessions. So if we had a good concept building. So I think at least the ophthalmology questions, they were pretty straightforward in a sense that you could attempt that. There will be 1 or 2 questions which will be relatively new, where they are tricking you, but I'm sure when in the days immediately after the exam के 2-3 दिन 4 दिन तक थोड़ा ज़्यादा हमें डर लगता है, but अगर आपने correctly mark किया है and you used your concepts, your foundation, your common sense, I hope the result will be very, very good for all of you. ठीक है? Right? Yeah, I agree, but that's like how the things they are. Okay, right. So yes, branching word I used to answer this question. Wonderful, Denchik. So that's the way to attempt the questions. So wherever you see a keyword, bring your memory, to that question, to what we discussed in the exam. So these two things, linear branching corneal ulcer, reduced corneal sensations, made our diagnosis very, very clear that this is the dendritic ulcer. So we do not know that whether they were asking the organism, that is herpes simplex virus keratitis, or they mentioned the term dendritic. Now obviously bacterial ulcers like pseudomonas do not have reduced corneal sensations or branching. Fungal ulcers, they do not have reduced corneal sensation or branching. They will have satellite lesions, feathery margins, etc. Acanthamoeba, very, very painful ulcer, no reduced corneal sensation. Mostly the ulcer is in the form of ring ulcer. So the other options, if they were similar to this, they were very easy to rule out, I would say. ठीक है जी? Now moving to the next question, beta. Now if you remember, if you had attended the 25 important questions with me, the similar question we discussed over there. A patient with pituitary adenoma presents with bitemporal hemianopia. So these two things again. Now bitemporal hemianopia, if you remember my friends, there is no other visual pathway lesion which causes bitemporal hemianopia. No, bitemporal means the outer part, the temporal part of the visual field is gone in both the eyes. So that will happen when the nasal retinal fibers of both the eyes, they have been damaged. And the nasal retinal fibers, they cross, they decussate, they are kind of clumped together in the optic chiasma area, central part of the optic chiasma. So if there is a tumor like pituitary adenoma which is compressing these fibers, and where the pituitary adenoma will compress these fibers, pituitary adenoma, the anatomical location is close to the optic chiasma area. So it has to be, the site of the lesion has to be optic chiasma. I'm sure again this question, see, the question cannot be more straightforward than this, beta. Examiner cannot be, posing a better question than this. Pituitary adenoma, bitemporal hemianopia, optic chiasma, these three things, they come in the same line. So optic tract will cause homonymous hemianopia, we know, okay, and optic nerve will cause monoocular hemianopia, not bitemporal, not hemianopia, monoocular visual field defect, and we know that occipital lobe lesion again causes homonymous hemianopia but with central sparing, and we know that pituitary tumors, they are present in relation to the optic chiasma. Okay, and this is how the bitemporal hemianopia presents. Okay, I'm sure this question was correct for all of you. I'm very sure. Right? Now moving to the next question, beta. A myopic patient has floaters and flashes of the light. On examination, a deep interior chamber is seen. What is the likely diagnosis? This question is a sort of past year question because question based upon floaters and flashes of the light has come earlier also in your Fmge exam. So there they had added that there is a curtain falling. Now even if there is no curtain falling mentioned here, floaters and flashes. Floaters, they occur because of the pigment in the vitreous. Flashes of the light, they occur when retina is being pulled. So what will happen if the retina is being pulled? So there will be a break formation. There will be a retinal hole formation. So this happens in the cases of, once the retinal hole formation is there are chances of development of rhegmatogenous retinal detachment. Okay? Acute congestive, Dr. Madan, acute congestive, if both were written, then the answer will be acute congestive glaucoma. Okay? Patient with pituitary adenoma, Radhika, if you see my 25 important question, most of the time these patients, they are depending upon which hormone is being excessively produced. They will have headache. Mostly prolactinomas are very common. So there will be menstrual irregularities. So these kind of the presentations, they will be there. ठीक है जी? किसका D आंसर था बेटा? आशी, which question you are talking about? So because option sequences must have been different in what were there in the exam, right? So if you can tell me what question you are asking, I can let you know what was the answer. Okay. So floaters and flashes of the light, why they have mentioned deep interior chamber? Because, like, the retinal detachments, they do not cause any changes in the interior chamber per se. Okay. So a bigger eyeball will have a deep interior chamber, and it is your myopes which have axial lengths which are more than the average axial length. So myopes, they have bigger eyeballs, so maybe they wanted you to know that the bigger eyeballs will have deeper interior chamber. So that was another clue, because myopia is the most common risk factor for development of rhegmatogenous retinal detachment. Agree? ठीक है बेटा. So this is how your rhegmatogenous retinal detachment will look like. Usually, if the retinal break is in the form of horseshoe tear like this, which I have shown here, that will lead to rhegmatogenous retinal detachment. So this patient will have floaters and flashes before the retinal detachment develops. Okay ji? ठीक है beta. So next question was again something like this. So this was also related to myopia in a way. Posterior staphylloma is seen on direct ophthalmoscopic examination of a patient. Okay. What is the diagnosis in this case? Again, we have discussed, we know pathological myopia is the type of the high myopia in which there are the degenerative changes occurring in the retina and choroid. Okay. Posterior staphylloma is the type of the bulging of the posterior part of the eyeball. ठीक है, जो posterior part है eyeball का, because in high myopia the eyeball is bigger in size. जैसे मैंने अभी बताया आपको, the eyeball is stretched out. So because of that, there is thinning in that area and there is bulging out of the posterior part of the eyeball, what we call as posterior staphylloma. ठीक है जी? So pathological myopia is the answer of this question, not hypermetropia, or if that was because hypermetropes, they have smaller eyeballs. Scleritis can cause staphyloma, but it usually causes ciliary staphyloma or equatorial staphyloma, not posterior staphyloma. Corneal ulcers, complicated perforated corneal ulcers, they can cause anterior staphyloma. So I think the question, if pathological myopia is there, posterior staphyloma is a feature of pathological myopia. So when you do the indirect ophthalmoscopy, so if you are able to appreciate here, so this is your optic nerve. So you see how much degenerative changes are there in the fundus because of the pathological myopia. And if you can appreciate here beta, यहाँ पे आप देखें, the central part, it's appearing as if the eyeball is stretched behind. There is a thinning in this area. So this is what is called posterior staphyloma. So the eyeball is posteriorly bulging out in one area like this, bulging out. Okay, right? Moving on to the next question. So posterior staphyloma दिया था बेटा, बस बहुत बढ़िया है. So I think, so it was, if it was given in the option, the question is other way around, that what will you see in the cases of pathological myopia? So that the answer will be posterior staphyloma. Okay? So I think then pathological myopia was in the options, was it? Okay. Now moving to the next question, beta, a patient has a painful swelling on the eyelid and a pus point is seen near the eyelash. Which of the following glands are involved in this case? Now, almost a similar question is there in our workbook beta. It's in the form of one-liner. यहाँ पे उन्होंने उसको clinical case की तरह present कर दिया है. ठीक है? A patient having painful swelling of the eyelid. Now, painful swelling of the eyelid is, it cannot be clesion because clesion is painless. It can be either your stye, hordeolum externum, or infected clesion. ठीक है, या जिसको हम hordeolum internum बोलते हैं, right? So these can be two painful swellings on the eyelid. Now if there is a pus point which is near the eyelash, so multiple times when I differentiate between clesion and stye, I tell you stye is a painful swelling on the lid margin. ठीक है जी। और लिड मार्जिन पे बेटा क्या होते हैं? eyelashes, cilia. So if there is a pus point which is in relation to the eyelash, it means we are talking about stye. In clesion, if it is infected clesion or hodolium internum, the swelling will be away from the lid margin because there are different glands involved in the two scenarios. So that is what your question was. So based upon the statement, I think you were able to identify that this is stye. They are talking about stye. ठीक है जी. If it is stye, then the gland involved will be gland of size because that is what is present at the root of the eyelash, and it will cause a painful swelling at the lid margin close to the eyelash with a pus point. Meibomian glands, if they are infected, they will cause infected clesion or they will cause a simple clesion, but in that case the swelling will be painless. Lacrimal glands, they are not present near the eyelash. Tarsal gland is another name of meibomian gland. Some people were saying that they mentioned the gland of Cross. So gland of Cross, as you know, is accessory lacrimal gland. Again, it is not present in the close to in relation to the eyelash. Okay. So Mahendra is saying that the question was cancer type, basal cell carcinoma, squamous cell, sebaceous cell. So with this option, the question was different, like painless, swollen between eyelash and upper eyelid. See, if it was painless, and it was swollen between the eyelash and upper eyelids, so then it means they are talking about meibomian glands. Then your answer becomes meibomian gland. So the answer will be whether the swelling was, question statement was talking about swelling like this, where the swelling is, as you see, at the lid margin. You can also see a pus point there. You can see it is close to the eyelashes. Then it is gland of Zeiss. If the swelling is between the lid margin, see, between the lid margin and the eyebrows, and it was a painless swelling, then the gland become meibomian gland, then they are talking about clesion. So clesion-like presentation is seen in sebaceous cell carcinoma. You also know that. ठीक है जी? Right? Okay. Beta, moving to another question which was asked in the exam, something like this, that a patient has difficulty in both distant and near vision. On examination, there is a limbal scar. अब इसमें क्या क्या note करने वाला था? Both distant and near vision. Limbal scar. Now, this was a very important word here if this was the question. Deep anterior chamber, what is the likely diagnosis? Okay. Now, what will be the scenario when only distant vision is affected? So that happens in myopia. We know that also happens when cataract develops. The person has difficulty in distance vision. ठीक है जी. Near vision, किन patients को difficulty होती है? When there is hypermetropia, when there is presbyopia because of the age, right? लेकिन यहाँ पे इस केस में patient is having difficulty in both distant and near vision. ठीक है? There is a limbal scar. So limbal scar means that this patient had surgery. So limbal is the area between the cornea and sclera. So corneal scleral incision was made, which led to limbal scar. So corneoscleral incision was made, which led to limbal scar. So corneal scleral incision was made, some surgery, this patient had some surgery. So if the patient had surgery, deep anterior chamber, so normally there is a lens which is hanging in that area. If there is no lens in that area, the anterior chamber becomes deep. So the surgery was done, but anterior chamber was deep and patient also has problem in both distant and near vision. It means the patient has no lens in the eye beta. I would agree this was a little tricky question where examiner wanted, but this would have been correct for all of you who had a good concept that if there is no lens in the eye, the patient will have both distant and near vision problem. Okay, post surgery, पोस्ट कैटरैक्ट सर्जरी, आपने नेचुरल लेंस रिमूव कर दिया, नया लेंस डाला नहीं, so there is absence of the lens in the eye, so that will lead to this kind of scenario, and the absence of the lens in the eye is called aphakia. ठीक है जी. If you put artificial lens, that is the lens implant, then that is called pseudophakia. So pseudophakia, the person who has pseudophakia or artificial lens, or you can say lens implant, what we call as intraocular lens, this patient will have normal distance vision, but may require glasses for near vision most of the time. Okay? So this patient will have normal distance vision. Okay? But if it is aphakia, no lens, if there is no lens, the both distance and near vision will be blurred, and this patient will require either aphakic glasses or contact lenses or a secondary intraocular lens. And because there is no lens in the eye, anterior chamber will appear deep beta. Okay? Why not presbyopia if something like this is there in the option? Because presbyopia, the lens should be there. There will not be the deep anterior chamber, no scar. Okay. Subluxated lens, if the lens is not in its position, again the vision can be affected, but mostly it leads to double vision. Subluxated lens usually leads to diplopia or double vision, and no, the limbal scar here indicates that they are telling you the past history of the surgery. Okay. Dislocated lens, again dislocated lens, if there is no aphakia mentioned, you have to consider the limbal scar beta. Dislocated lens, if it is due to trauma, then there will be no limbal scar. It can cause both distant and near vision problem. It can cause deep anterior chamber, but there will not be limbal scar mentioned in the statement. So, Dr. Denchik, if dislocated lens should be the option, then limbal scar word should not be there in the there. Okay. Yeah, so I think, I don't know whether that was a separate question that the patient was using 11 to 12 diopter lens. So I have put it as a separate question because some people, they were saying that this is another question asked there, which was actually related to aphakia. Okay, ji? Okay, so moving to the next question, which was image based question, and a very straightforward question, past year question, I would say. Identify the lesion given in shown in the given image. So an image similar to this was there in the exam, which was showing some lesions on the limbus. So if the image was similar to this, you could see these small pit-like lesions on the limbus. Pit-like lesions on the limbus. So okay, Kalyani, if that was the same question, then that was another hint that it is, the answer is aphakia, right? So here, the for this particular image based question, the answer is Herbert pits. Why not follicles if that is the option? Because follicles, they will be raised. Pits, they are these small depressions. Penis is a vascularized corneal opacity. Vascularized corneal opacity. Now all these, they are feature of trachoma, but the picture clearly is showing you Herbert pits beta. TKG and Horner Tranta spot, as you know, they are seen in VKC. I think there should not be confusion in that. Now Mahendra is saying this time questions, they were similar questions of two but different options. Oh, so it means like if they were similar topics, so the chances of rather attempting the question right is more because they are from the similar topic. But that's a good strategy for the future students who want to appear, that they can ask the similar topics in the same exam as well. Okay. Okay, beta. Moving to the next question. A patient presents, again, there was some question related to the pupillary reflexes. So you can let me know what was the exact question, but I think this was something like a patient presents with pupil not reacting to light but near reflex is present. Okay? Pupil not reacting to light, near reflex present means accommodation reflex present. So the diagnosis was Argyll-Robertson pupil, Argyll-Robertson pupil, but most likely the question asked was that what is the site of the lesion. Now this particular question I will say is a relatively newer question for our FMG students, because so far they have not asked the site of lesion of the pupillary abnormalities. Okay? So if it was an image question, so they must have shown you an image like this, pupil wala beta, that the pupil is not reacting when you bring a torch light to the pupil. Pupil does not constrict, means near reflex is absent. Here near reflex is absent. Light reflex is absent, but pupil reacts briskly to accommodation when you bring a near object like a pen or finger close to the eye. So the diagnosis is Argyll-Robertson pupil. Okay? And if they were talking about the Argyll-Robertson pupil and they asked the likely site of the lesion, so then the likely site, the most common involvement is in the pretectal area of the midbrain beta. In Argyll-Robertson pupil, the lesion affects the pretectal area of the midbrain, because this is the area where your interneurons are affected, which are responsible for the near reflex, Yes, it's right. The abnormal pupil will be in AR pupil, the pupil, they are small and myotic, as it is mentioned in this image also. The pupils, they will be small, they will be slightly irregular and myotic. They will not react to light, they will react to near reflex. Yes, it is seen in neurosyphilis, the very common cause of AR pupil, also seen in some of the diabetic patients. The site of the lesion is the pretectal area of the midbrain, where the interneurons which are responsible for the near reflex, they are located and they are affected. Okay, beta? Okay. Moving to the next question, beta. So this was a question related to the corneal ulcer with a history of contact lenses. Is that correct? That a young girl using contact lenses complains of pain in the eye and decreased vision. There is history of using tap water or unclean water for the lens cleaning. What is the likely cause for her condition? So some question related to contact lenses with unhygienic practices to clean the lenses. So if these things they were there in the question statement, so we know acanthamoeba will be the answer for this, because when you are using river water, tap water, when people they go for camping or some sort of picnic or outdoors, and if you clean your lenses with the water which is from the rivers or like that, so that leads to the risk of developing acanthamoeba keratitis. So I think if acanthamoeba is the only choice and pseudomonas was not mentioned, then it becomes a very straightforward question. And I think the pseudomonas was not in the option. Okay, but acanthamoeba was. We know the herpes simplex and the fungal, they do not have any additional risk factor related to contact lens use. Even pneumococcus is not the common bacterial infection which occurs. Pseudomonas is the most common. So if acanthamoeba was there, acanthamoeba will be the answer. Okay, ji? Moving to the next question, beta. A patient presents with deviation of the eye and the reflex is as shown in the image. What is the degree of the deviation? Now again, exact question whether they asked about just the type of the deviation, that is a squint, or they asked about the degree of the squint, that needs to be confirmed by you people. But the image was, I think, certainly there. The image was certainly there, which showed the eye in that outward position. Was it so? Right? So when the eye is in outward position, outward deviated. Okay. Now this eye is outward deviated, so that you know very simple that it is exotropia. ठीक है. If they asked about that how much degree, that is they wanted to know interpretation of the Hirschberg corneal reflex test. So here if you note and if it was similar to the what was shown in the exam, the reflex, so reflex in this eye is in the center, whereas in the affected eye is at the limbus. So when it is at the limbus, we say that either it is 45 degree of the squint, which is equivalent to 90 prism diopter. Okay, so they mentioned exotropia and the option was exotropia 90 prism diopter. So that's perfect. Esotropia. So I think then this question again would have been an easy one for you. We have discussed Hirschberg. We know what exotropia looks like. So esotropia is out of question here, and it is 90 prism diopter, not 90 degree. 1 degree of the squint is equal to 2 prism diopter. So if it is in the center, then it is no squint. If it is the pupil margin, then it is 15 degree or 30 prism diopter. If it is midway on the iris, then it is 30 degree or 60 prism diopter. When here it is at the limbus, it is 45 degree and 90 prism diopter. Okay, so आई थिंक आप जैसे बता रहे हैं आप सब लोग, आई एम श्योर ये क्वेश्चन भी आपका ठीक हुआ होगा. ठीक है जी, राइट. Okay beta, moving to the next question. So this was probably another question which was related to the nerve palsy. अगर डिग्री नहीं मेंशन करी थी अंकिता फिर तो और भी इजी है, जस्ट एक्सोट्रोपिया. ठीक है. A patient presents with eye which is down and out and with ptosis. Which of the following palsy is present in this case? So again, down and out position of the eye. बेटा down and out position, अगर ये दो words भी question statement में कहीं लिखे थे, तो we have been kind of, remembering this many times frequently, that third nerve palsy is the nerve involvement in which eye is in down and out position. Why? Because all extraocular muscles other than lateral rectus, which moves the eye out, and superior oblique, whose secondary action is to move the eye down, they are normal. Rest all are either weak or completely paralyzed. Okay, ji? So down and out and ptosis. Okay. So nerve palsy with down and out eye and ptosis, no doubt in your mind it should be its third nerve palsy beta. And we discussed the similar question in 25 important question session. So अगर 25 important question session हमने किया था बेटा और उसको attentively सुना था, तो 2-3 question तो straight forward वहीं से हैं आपके. 3 questions, one based upon adenoma, one based upon third nerve palsy, orbital blowout fracture, and similar things we discussed for acanthamoeba ulcer, everything beta. ठीक है जी? Right? Okay, so this is how your third nerve down and out position of the eye. Why this is eyelid is being lifted? Because of the ptosis. Okay, so the option is congenital third nerve, supranuclear lesion something, and pseudo. Okay, so this was not an old patient, it was there. But again, if this was mentioned, beta, ptosis is there and third nerve palsy is there, because third nerve palsies, they can occur with congenital ptosis. So you will call it as, remember, complicated ptosis. That is an example of complicated ptosis, but involvement is because of the third nerve, because third nerve supplies your LPS and all other extraocular muscle except for lateral rectus and superior oblique. Okay? So thank you for adding to the question, Mahendra, that it was a child which was brought with ptosis since birth and down and out. So once down and out and ptosis, that this 3 combination is there, whatever is the age, the involvement is of the third nerve beta. Okay? And then another question which was there was, as you were discussing with me about in aphakia, was related to that a man is wearing plus 12 diopter or plus 11 diopter of the glasses, spectacle correction, what is the likely reason? So this question, whether it was a combination with the aphakia question or it was a second question related to similar topic, but you already told me that answer should be aphakia, because when there is absence of the lens, if you remember beta, total refractive power of the eye, okay, total refractive power of the eye is plus 60 diopter. ठीक है, हमने डिस्कस किया हुआ ना, and I always tell you to remember it is like 45 diopter contributed by cornea and plus 15 diopter contributed by your natural lens. ठीक है, तो अगर natural lens absent है और implant भी नहीं डाला है, pseudophakia भी नहीं है, so your eye is short of or it is devoided of plus 15 diopter of the refractive power, वो चली गई. So this will happen in aphakia. So to compensate that, to correct that much of refractive error, either you will give high plus glasses to the patient, something like plus 10 to plus 12 diopter, okay, or you can give contact lenses to the patient, or you will implant intraocular lens as a secondary procedure. Okay, so if your person is wearing this much of correction, then it is because the person is aphakic. In pseudophakia, you are implanting a lens which is going to correct the distance vision for the patient. लेंस पावर निकालते हैं ना मायोल फार्मूला से, SRKT formula etc. So because you are implanting the power lens there. Presbyopia, most of the time the range is between 0.5 to 3 diopter is the correction which is usually needed to correct the presbyopia, not such a high glasses. Even the lens is subluxated, so it will rather cause double vision, and you might need to correct the patient by giving astigmatic glasses because the lens is subluxated. Only dislocated lens might need this kind of spectacle correction. Okay, so when there is no lens in the pupillary area. Okay, ji bache? Right? So this was the compilation of the questions which I could collect beta. There must have been some more questions if they were, but by discussing these questions, I'm sure that you could have attempted most of the questions correctly. So, ठीक है बेटा, अगर ptosis में lid lag था, so again the answer will be, it will not change the answer. The answer will again be third nerve beta. Because congenital ptosis can present as simple congenital ptosis, there is no additional problem, or it can present with third nerve palsy, in which the eye can go down and out and along with ptosis, or it can be complicated ptosis like, if you remember last time they asked about Marcus-Gunn ptosis or blepharophimosis syndrome. So all these they can present with congenital ptosis. Okay, so even if they mention lid lag, the answer remains the same. Okay, beta. So I wish you all the very best. I'm sure you guys are little bit anxious at the moment for your result, which is very much natural. But after seeing these questions, which were recalled by you people, especially in the ophthalmology, I'm sure you were able to attempt at least 90% of the ophthalmology questions correctly. And I'm very sure about that. Thank you so much for such an interactive session. You can add something in the comments later on as well, if you want to add on to any more question or anything like that. I wish you all the very best for your result. Okay? Yeah. So since birth, that is why Mahindra, they try to confuse the students by mentioning that it is present since birth, but that does not change the nerve involved. That will remain third nerve. Okay? So all the very best. My blessings are with you, beta. All of us, we are rooting for your success and a very good result. Take care and all the very best once again. Thank you so much.